All right, so other angle-based surgeries. The first microinvasive surgical implant to be FDA approved is the Eye Stent for use with ocular hypertension, mild open-angle glaucoma, to be done with cataract surgery. And you can see it's a pretty neat little device. It's this snorkel that is meant to be implanted through the trabecular meshwork into the canal. Problem is that it limits future surgeries. If you do this, you can't do canaloplasty or other procedures that require access to that area of the canal. And it's damn expensive. I mean, this device is the smallest FDA-approved surgical implant ever. Okay? It's made of titanium, and per ounce, this is the most valuable, expensive thing you could ever purchase. Okay? I think that, some rare man-made element that you have to create in the Hadron Collider may be more expensive than this. Okay, but per ounce. But this is well reimbursed. It's the implant itself is $1,000, and that's about what the surgeon is paid for implanting one of these. So they've become quite popular. The question is, do they work? And here's a video from Ike Ahmed, who is just a truly expert surgeon, and has had the ability to be involved in a lot of these new surgical procedures, done a lot in terms of figuring out how best to do these things. And this is him performing the surgery. And as with all of his surgeries, it's just elegant to watch. You can see him implant this stent, and he makes everything look so easy. But one of the things about this particular video, which underscores the issue with the Eye Stent, is you're going to see in this video he does not implant one, does not implant two, he implants 3 of these in the eye. Now, if you implant 3 of these in the eye, you should get an effect. But the problem here in the US, separate from Canada, is you're only going to get paid for 1. And at $1,000 each, good luck finding a surgery center that's going to eat the extra $2,000, or a patient who's going to be willing to pay for the extra $2,000. But you can see how this goes into the canal through the trabecular meshwork. And I just love watching his videos. I can't think of too many eye surgeons who don't. His work is so nice. Anyway, so his surgical technique, absolutely fantastic. How about the results of the Eye Stent? Do they match his surgical technique? No, they don't. Okay. The 1-year results of the Eye Stent. Okay. Cataract surgery alone is done. The pressure is reduced by the percentage of patients who achieve a pressure lower than 22 millimeters mercury, 50%. So half of the patients, just from cataract surgery alone, will achieve that pressure under 22 millimeters of mercury. How about if you put the Eye Stent in with cataract surgery? 72%. Okay? So yeah, you do get more, but the majority of the reduction there is from the cataract surgery. You say, okay, well, that some of these drops can be pretty expensive, right? I mean, we've all got patients who are saying, doctor, that drop that you prescribed me, the Simbrenza, is $250 a month. Well, a year of Simbrenza, and this is paid for itself. So maybe not so impressive when you're looking at the difference between cataract surgery alone and cataract surgery plus the Eye Stent, but taking a bigger picture, it can be a useful option. But 2 years after surgery, there's no statistically significant difference between those who had cataract surgery alone and those who had cataract surgery plus the Eye Stent. So it's easy to put in. It's currently paid for by insurance, but is it really going to give us a long-term benefit? Probably not. So what other options are there? Well, just recently, at the end of 2016, the FDA approved the Cypass Microstent. Now this is exciting because this is using an outflow shunting method that has not been available to us before. Okay? Now this is also, like with the Eye Stent, only approved for those who are also having cataract surgery. Okay? But the nice thing about this is because it uses a separate outflow, it can be used even in patients who have had or may need to have other glaucoma surgeries. Okay, and sorry, I want to show you this, this video here. So this is showing the outflow pathway, showing essentially both the pathway through the trabecular meshwork as well as through the uveoscleral outflow. You can see that this is it's essentially a tube, right? But it's a tube that's designed in such a way that it can atraumatically sit in the supraciliary space, right? So you can see that right in the angle above the ciliary body, and shunt fluid into that space. And it's a very quick procedure. So basically, you make an incision just like you would with cataract surgery. You fill the eye with viscoelastic, and I'm not sure that we need to see all the details of this. And you have this injector. It's placed into the angle and simply inserted into the supraciliary space. And there it is. So the question, of course, is how well does it work? So if we look at 2-year results, and we do have 2-year results on this, they looked at patients whose diurnal curve was between, I think it was 8 millimeters of mercury or 6 millimeters of mercury. That's right, 6 millimeters of mercury and 18 millimeters of mercury. And 61.2% of patients with the Cypass maintained this range versus 43.5% with cataract surgery alone. So again, what you see here is that cataract surgery alone does have a beneficial effect in treating glaucoma. So more, however, experience this range of diurnal curve with combined cataract surgery and Cypass. If we look at the absolute pressure reduction, 7 millimeters of mercury with the Cypass versus 5.3 millimeters of mercury on average with cataract surgery really doesn't look that impressive, right? Less than 2 millimeters of mercury. But if you look at the percentage difference, it was 32%. And again, what we're going to find is that with all of these lower risk microinvasive surgeries, we don't necessarily have to think of just one. We could potentially think of building up on different surgeries using different outflow pathways in order to achieve a reduction that could potentially end up in the same range as trabeculectomy or glaucoma drainage devices, but without the vision-threatening complications. And if we look at the 2-year results in terms of the percentage of patients who achieved a non-medicated pressure of 20 millimeters of mercury or less, so 20 millimeters of mercury or less without drops, 72.5% of patients with the Cypass achieved this versus almost 60% with cataract surgery alone. Okay. In terms of adverse events, there really weren't that many. When you look at the comparison of the combined Cypass with cataract surgery versus cataract surgery alone, overall quite similar. So it seems to be a pretty safe device. Also approved at the end of 2016 by the FDA, the Zen 45 Gel Stent. This is a chemically treated gelatin tube. It's basically what it is. It's a tube, but it's been designed so that the aqueous flow through it is restricted in such a way that it reduces the risk of hypotony. So this is essentially an ab interno method of trabeculectomy. You're shunting the fluid into the subconjunctival space, so it still requires a bleb to achieve intraocular pressure lowering, and as such, it still has all of the potential complications, or most, if not all, that trabeculectomy would. The issue with this is that although it shares many of the complications with trabeculectomy, and although it's much faster and in some ways easier to do, it doesn't seem to do quite as well as trabeculectomy in terms of pressure reduction. So the average drop of 30% from 20.8 to 14.4 at one year. Not quite as impressive as trabeculectomy. 3-year results looked pretty good. 40% reduction, 75% medication reduction. About 5% of participants needed to go on to additional surgery, which is pretty typical for glaucoma surgeries. But as I was saying earlier, you have these issues of short and long-term hypotony, potential for loss of vision. Okay, that's not insignificant, right? 6.2% long-term loss. So that's on par with really trabeculectomy. Cataract surgery. I'm not going to belabor this point. You've seen already from the studies I showed earlier that cataract surgery alone can be effective with glaucoma. So for many of our patients who are kind of doing pretty well with their glaucoma, we'd like the pressure to be a little bit lower. They may be having some progression. If they've got cataracts that are ready for surgery and they're not maxed out on medications, then cataract surgery alone for many of these patients is perfectly reasonable. The issue, though, is if they are maxed out on medications and you perform cataract surgery and they have a pressure spike, which is not uncommon among glaucoma patients who have cataract surgery, then what are you going to do? Then your only option is Diamox. So patients who are on max tolerated medical therapy and need cataract surgery, we will generally consider combining the cataract surgery with one of these MIGS procedures. But if they're not maxed out, it's perfectly reasonable to consider just cataract surgery alone in those who have mild